Thank you, Dr. Sanjeev and Rajasthan Cardiology Society for inviting me for this talk on retrograde simplified. When we go to retrograde is when proximal cap is not clear and when distal vessel is not clear on angiography and when the course is ambiguous and when you have a good interventional collateral present in the case, that is when we go retrograde. And my default strategy, also in many operators across the world, is antegrade preparation followed by retrograde, except in certain situations where I want to minimize contrast load or where antegrade is not at all available or the guide is unstable, that is aorto-ostial lesions. So that's where we go direct retrograde. So this is a direct retrograde. See, this is ostial RCA total occlusion, and you can see CT clearly showing total occlusion of ostial right coronary artery. So you have only one axis that is direct retrograde. But in all other cases, it is antegrade preparation followed by retrograde. And in this special circumstance, that ambiguous ostial LAD CTO, so wiring strategy is very important. If you just go antegrade without IVUS and you lift a flap and occlude LCX, then you will have an on-table catastrophe. And if you go retrograde without antegrade preparation and close LCX with by entering an LMCA, again, you'll create a problem. So to prevent such catastrophes, the best strategy here is go IVUS guided antegrade cap puncture has to be done first. And then if you can't reach distal true lumen, go retrograde and then do reverse cart beyond the ostium. So that's key. Your retrograde wire shouldn't come to ostium. So this is the best strategy for ostial LAD or ostial LCX CTOs to prevent catastrophes on table. Before moving to retrograde, so what we have to make sure is one, interventional collateral, 1, 2, 3. What are the options you have? You have to figure out. And what is the strategy of connecting spaces? Yes, you go retrograde, but you should have a strategy to connect spaces. And then what are you going to do after crossing CTO? Are you going to externalize or no externalization? So answer all these questions and then move on to retrograde. And coming to interventional collateral selection and wiring, see, we have 3 interventional collaterals. See, the best is, SVG graft if available. So in post-CABG patient, even SVG graft closed an ear back also can be used as a conduit. The next best is subtle collaterals. And the last one is the epicardial collateral in terms of safety of intervention through these collaterals. Whenever you are choosing collateral, you have to be mindful of the donor vessel lesions. Are there any lesions proximal to the collateral you have chosen in the main vessel? That's very important, which also decides your strategy. Let's say there is a donor vessel disease, as in this case, you have a disease in LAD, in RCS CTO while going retrograde through LAD. So always have a safety wire in LAD. That's a rescue wire. If something goes wrong to the LAD, you can quickly rescue the patient if you have a wire in donor vessel. And sometimes, if you have a critical lesion in donor vessel, like here in RCS CTO, there is a 99% lesion in LAD. You have to address these critical lesions before moving on to retrograde. Otherwise, you can have a catastrophe on table. See, we stunted LAD, and then we went across the struts and did retrograde PCI to the right coronary artery. So treat always critical donor vessel disease before going retrograde. That's to improve your safety. And if there is only dominant single collateral, like in this case, where one subtle collateral is filling enter PDA, when you enter such collateral and send your microcatheter in, then your recipient vessel will lose the blood flow and patient may go into ischemia. So always have an alternate plan if there is only one dominant collateral filling the recipient vessel. In epicardial collaterals, see what matters here is not the loops, it is only the size. So if you have a good size, the wires which we have right now, like CO03 wire, you can see how this wire goes across these kind of loops, and how easily you can reach your recipient vessel without much difficulty. So size matters, not tortuosity in epicardial collateral. And in septal collateral, see, sometimes septal collateral can be connected to RV branch. We have to be very mindful of that. So always choose a collateral which is connected to PDA, not to the RV branch, because these collaterals, they traverse through acute angles. And when you try and send a microcatheter across such angles, you might end up in perforating these collaterals. So be mindful while choosing septal collaterals. And takeoff of septal collateral is a key. You can see these kind of takeoffs are very difficult to enter, but you can use a double lumen catheter or sometimes even angled microcatheter. And also you can use reverse wire technique to enter these kind of septals. And when septals are branching, so too much of branching is not ideal for crossing septal collaterals. That's where we end up in failing crossing septal collaterals. If you have a straight single collateral, it is very easy to cross. You can see in this case, we tried the first septal, but we failed. And finally, I had to take this single septal collateral and crossed. So keep trying, first, second, third, you have to choose your septals and go on chasing them. So always straight vessels are better. And entry into the recipient vessel is again very important. You can see here how the septal collateral is entering into the PDA here. So it's almost like a reverse loop. So here your wire only goes distally, you can't go proximally. So this kind of entry is quite good, where your wire goes into the proximal RCA. You can also see here PDA. So PDA is almost coaxial with PLVB. It is very difficult to turn your retrograde wire into proximal RCA. So be mindful of such angulations, which makes your retrograde more and more difficult. So wiring collaterals, these are my choices. For septal collateral, almost even CO03 became my default if there are loops. Otherwise, cyan is another choice. And I use cyan block and filter when I'm not able to cross with these first two wires. And for epicardial collateral, CO03 is the best possible wire and very low penetration force. And for graft, SVG graft, I generally chase it with pilot with Corsair Pro support. And microcatheters, again, it depends on operator. See, my first choice for septals is Corsair Pro XS. If I'm not able to cross with XS, then I need more pushability. Then I'll move on to Corsair Pro. And sometimes we exchange with these catheters like Caravel, Fine Cross, Turnpike LP. When I have too many loops, not able to navigate with Corsair, we can use these catheters. For epicardial collaterals, Caravel is the best, atraumatic microcatheter. And as I already mentioned, for SVG Corsair, I generally use and wide crossed, but microcatheter not crossing collateral. So that's very common scenario in present days because of the increased wiring technology, which makes us cross even different kind of loops and even almost invisible septals. So what you can do is first increase support for your microcatheter push. So you just send your retrograde wire deep into PLVB or deep into diagonals, and then push your microcatheter. If that doesn't help, then you can anchor a balloon in a retrograde vessel, and you try and push your microcatheter. If that doesn't work, then you can just dilate your septal collateral itself and to send a microcatheter. Then if that is not working, then change the collateral, move to another septal and do it. If that is also not working, so you can also switch strategy to a different strategy like marker wire technique or ADR. So you can see here, so we tried antegrade puncture in this ambiguous CTO with IVIS. And as the distal vessel is not clear, we just went retrograde and crossed septal collateral, but microcatheter was stuck in septal collateral, did everything but not able to cross. Then what we can do, just loop your retrograde wire here and use this as marker, and then advance your antegrade wire towards that marker. And we completed procedure that way. And also we can use in certain cases where you're stuck. This again, ambiguous cap CTO did an IVIS guided puncture, but wire ended up in subintima distally, though the entry is correct, and went retrograde. You can see here, fine cross stuck here, changed to cord side for pushability, cord side stuck here, did all the support measures as well as balloon dilatation, but still cord side got stuck there. Then what we can do is loop the wire at the distal cap and go with the stingray. By using your retrograde wire as a marker, you can do stingray entry, stick and continue approach. So, and you can complete procedure. So once your microcatheter is distal to the distal cap, so what's the next thing we have to do is connecting spaces. So what are the options? Either you can send your retrograde wire into antegrade space, or send antegrade wire into distal vessel using your retrograde wire as marker. So these are the options. And the most common methodology used by most of the operators is the reverse cut, that is sending your retrograde wire into antegrade space by using reverse cut. That is almost constitutes 60 to 70% of retrograde cases. And you have to choose a site for reverse cut. So always best is within the lesion, and choose in the straight segment of the vessel and a non-calcified area. And during procedure, if you have knuckled, go to an area where you have not knuckled. So in this case, you can see this is the ideal site, where you can do a reverse cut. And the best is now direct reverse cut. So what we do here is do an antegrade wiring, antegrade preparation first, then go retrograde and go with the microcatheter, then take an antegrade balloon, smallest balloon like 2 mm balloon, then take a directable wire like Gaia 2 or Gaia 3 retrogradely and direct this wire towards the end of the balloon or side of the balloon, either end balloon technique or side balloon technique. So this is the best technique, because we create minimal wide space and success is maximal and also quick. So you can see here, so what we did an antegrade wiring, antegrade preparation, then went retrograde microcatheter and shifted to directable wire, that is Gaia 2, and came with the antegrade 2 mm balloon, and in two orthogonal views direct the wire towards the balloon and deflate, and then complete your procedure. So this is directed reverse cut. This is a most common reverse cut which we use. Obviously, this creates less number of tracks and increases success of connection in shorter time with minimal injury to the vessel. And sometimes when your directed reverse cut is failed, especially in vessels like this, where vessels are very loopy. So what you can do is take a balloon which is equivalent to the size of the vessel and then direct your retrograde wire towards that balloon. So this is a conventional reverse cut, so which we use in these kind of situations, generally after failed reverse cut or calcified lesions or tortuous CTO segment. And in ambiguous cap CTOs where you're just gone retrograde, so you can, if the vessel is not, size is not significant, you can just take a extended reverse cut. You will do proximal to the lesion. So inflate the balloon and send the wire into the space. This is the extended reverse cut. So these are the reasons, where your reverse cut can fail. And when your reverse cut fails or taking more time, you can just do a quick IVUS interrogation, and then you will find the reason. You can see here, wire is subintimal here. So, and as I come proximally, the wire got intimal, and again, it goes subintimal. So that's what happens in a long CTOs. So that's when what you have to do is you have to identify where the wire is intimal. So this is where wire is intimal. So then what you have to do is just push the microcatheter to the site where it is intimal and bring your guide extension to the site where it is intimal, and then you just externalize. And if you have wires in different spaces, see why both antegrade, retrograde in intima, antegrade, retrograde in subintima is easy to tackle. This is how you can tackle. And if antegrade is subintima, retrograde is intimal, or antegrade intimal, retrograde subintimal, this is where your wire has to go across an intimal layer. So you have to use a high tip load wire to go across and cross and do a successful reverse cut. And after reverse cut, what do we do? So once your wire is in antegrade space, so you advance this wire into antegrade guide. But in cases where the vessel is deceased, proximal vessel is deceased or tortuous, or you had a difficulty in doing in reverse cut, then use a guide extension catheter and then external and send wire into guide. Once the wire is in your antegrade guide, you can externalize, or you can do a tip in and go get an antegrade access without externalization. See, if there is a disease in donor vessels proximally, I prefer not to externalize. I take an tip in and take an antegrade access and finish the procedure. And you can see here, so where guide is not coaxial with the vessel, so the best is it's difficult to externalize. Take a guide extension and externalize. And in aorto-ostial CTOs, there is no antegrade access. So obviously you need to externalize by snaring. So you have to have a strategy of snaring. Better is snare in descending aorta. So in this case, the wire went into subclavian. So we snared in subclavian. So descending thoracic aorta is best to snare, so to avoid embolization into cerebral vessels. And once you snare the wire, you trap your advanced microcatheter into antegrade guide, entrap microcatheter in the guide, and then exchange wire and externalize. After externalization or tip-in, once you complete your procedure, and before coming out, you have to screen for collateral and donor vessel injuries. You can see here, so in an epicardial collateral, always use a kissing microcatheter. So send microcatheter from the both ends of externalized wire, and then you pull your wire out to one side. And while injecting, you can see here, while injecting, you can pull your microcatheter back. If you see any external extravasation anywhere, you can stop with the microcatheter, and then you go ahead with coiling with 0.014 coils, which are available from Cook. So you can see pulling microcatheter while injecting. So if there is an externalization, extravasation, just stop the microcatheter there, and then go back with the coil and coil it. And in subtle injuries, you can see here, so subtle got injured after retrograde intervention to right coronary artery. Always occlude the injured side from both sides, either it is epicardial collateral or septal collateral. You have to occlude from both sides of perforation. And donor vessel injuries is something which is very important to look for while coming out of case. You can see here, we went through a subtle distal to the stent in the donor vessel, and we ended up in dissecting vessel here, so which again we stented. So imaging is key. The final step in my CTO intervention is IVUS imaging of entire donor vessel along retrograde course. So that's where I end my procedure. To conclude, aorto-ostial lesions, default strategy in retrograde is antegrade preparation followed by retrograde, except in cases where aorto-ostial lesions and while minimizing contrast. And in ambiguous cap, ostial LAD, LCX, IVUS guided cap puncture followed by retrograde is a key. And before switching to retrograde, make sure what is your interventional collateral. Define your connection of spaces. Define whether you are externalizing or not. And safest conduits are venous grafts followed by septal and then epicardial. Collateral takeoff and angle of entry into recipient vessel is key in before you start exploring collateral. Awareness of sub-algorithms for problems like microcatheter not crossing, difficult reverse cut, difficult externalization are important to bail yourself out of the procedure. And after procedure, before coming out, look for donor vessel injuries and collateral injuries. Thank you.